Okay, sir. 48-year-old male came with a chief complaints of right plane pain since 4 months.
Okay. Would like to move to the history of present illness.
Pain was gradual in onset, dull aching in nature, intermittent, and no aggravating factor. Subside with taking oral analgesic.
Okay. Was there any radiation of the pain?
No radiation.
Okay. Next.
There is no history of fever with chills, no history of nausea, vomiting, no history of any urolithiasis, pyuria, lithuria, hematuria, and no past history of any intervention in form of any catheterization or other surgery.
Okay. In any other relevant history? Pass.
Past history, no history of hypertension, diabetes, or tuberculosis. No history of any surgical intervention in the past. Family history not significant. Personal history, patient was taking mixed diet, appetite normal, sleep normal, bowel habit regular, and no any addiction.
Yeah, we will not go too much into the history today so that we can discuss more about management. But roughly, what will be your thoughts? Etiology-wise, what are the differentials? Quickly, so that we'll proceed.
So, in this patient with 48 years male patient with flank pain, I would like to think of firstly stone disease, renal calculus disease. Then hydronephrosis secondary to PUJ obstruction or PUJ calculus, chronic pyelonephritis under inflammatory conditions, GUTB. Then he can have benign kidney lesions like cystic disease of the kidney or other rare benign lesions like angiomyolipoma, metanephric adenoma, or some other rare conditions. Or he can be having a malignant condition like renal cell carcinoma or upper tract urothelial carcinoma.
In this, you said chronic pyelonephritis.
Yes, sir.
So you mean to say that patients with chronic pyelonephritis will present with right flank pain?
Yes, sir. In the absence of any fever or any recent history of UTI, a patient can be having underlying past inflammatory lesion in the form of chronic pyelonephritis.
See, the pain component is always, by default, it is the acute part. Okay. When you talk of chronic pyelonephritis, let's assume this is a case of VUR. And the child has some 1%, 5%, 20% function. That's called chronic pyelonephritis, if you go by the definition. So the kidney which is poorly functioning usually also does not produce any symptoms. It can produce proteinuria, it can produce hypertension and other things. It contributes lesser to the function. But remember, when a kidney is poorly functioning, it's usually silent.
Okay.
So, to say that pain in the right flank of 4 months duration is due to chronic pyelonephritis, you have to think why it should producing. Unless some acute component is added on it, it usually does not produce.
Yes.
Okay. Again, you said GU tuberculosis without any constitutional symptoms, without any family history, without any lower tract symptoms, no fever. It's too I mean, just a patient presents with 4 months history of flank pain put as due tuberculosis is too much. Anyhow, so these were the differentials. Anything is possible, but I mean, you will not put that as a differentials. You may get surprises. You should be open to it, but you would definitely put a PUJ or stone disease or other malignant conditions. Fair enough. Okay, proceed. What examination, please?
Examination findings, sir.
Anyhow, all normal. So we'll proceed. What?
Yes.
Okay, anything else?
Not one thing. Patient is likely to have a low BMI, sir. A height of 175 and weight 60 kg. History.
Yeah, next.
No significant findings on local examination.
We'll proceed.
Yes, sir.
Yeah. Next.
Almost normal findings on urinalysis. Normal counts are there. Hemoglobin 15, which is normal. Other counts are also within normal limits.
Yeah, we'll go to imaging, no problem.
So we have got ultrasound images of the left kidney and the right kidney here. On the left kidney, the kidney appears to be normal in size, shape, and contour. And the ecotexture is well maintained with normal corticomedullary differentiation. No, there is a well-defined hypoechoic lesion with normal contour and borders, likely to be a cystic lesion. There is no evidence of any hyperechoic or structure or calculus, or there is no evidence of any fullness or hydronephrosis. So on the left kidney, it's likely to have a simple cyst in the interpolar region. On the right-sided image, we have the image of the right kidney.
1 second, Priyanko. What are the features of a simple cyst on an ultrasound? Something you have missed. You don't say normal contour.
Okay. Sir, the luminal content is echo-free with no wall calcifications, no septa, or any no intervening septa, or no echogenicity within the lumen.
So what happens to the opposite wall?
Sir, there is no.
Can you see the opposite wall carefully and tell us what happens there? Enlarge the image if needed.
Yeah. Left side. There is a fine enhancement like appearance on the wall.
Use proper terms. Now, what is enhancement in ultrasound?
Okay. Hyperechogenicity. There is the wall of the cyst on the
See, what all you want to describe? You want to describe the location of the cyst, the size of the cyst, the exo-endophytic, what is the content in the cyst, whether it is separated, whether the wall is thin, whether there is calcification, whether there is post-acoustic shadowing, right?
yes.
These are things you will have to describe. Not only describe the cyst, but surrounding area or behind the cyst or whatever.
Okay.
Whether the wall is thin-walled, whether the wall is calcified, whether they are septate, whether the content is clear.
Yes. The wall appears to be thin wall except in one region where there is a little, there is an hyperechogenic area without any acoustic shadow. Otherwise, the wall is a thin wall without any luminal, solid, or echogenic content. There is no evidence of any septa.
No, Priyanko, I want to understand why that opposite wall is hyperechoic. It's a normal finding, let me tell you that. I just want to understand why that opposite wall is hyperechoic. Anybody wants to help him out?
It's not sure, sir, regarding this.
So which means either you fellows are not reading or you are reading without understanding anything. So, because the ultrasonic waves can travel through the anechoic cyst much better than the tissue, therefore, as compared to adjacent tissue, the opposite wall appears more hyperechoic. Do you understand?
Yes.
Okay. Now you go to the right kidney.
The right kidney appears to be distorted in its contour with evidence of a mixed echogenic mass lesion in towards the lower pole. The size cannot be ascertained here. There is no evidence of any fullness, pelvic ileal fullness or hydronephrosis or any calculus. In the subsequent images of the right kidney, on the left side we have the sagittal view and the cross-sectional view on the right side.
See, if you are able to describe, fine. If the upper, lower pole size, anything was not marked, you won't be able to tell it. We'll proceed. Probably we'll have more images on CT or something like that. We can discuss about it because this is not clearly defined here, so fair enough. The rest of the bladder. Okay, you want to see the report? You can see.
Right kidney measures 14 by 6.7 by 1.4 cm. No hydronephrosis or calculus. There is a mass lesion of 9.3 by 6.6 centimeter size in the lower pole. Left kidney has normal findings with size of 9.5 by 5.1. There is a simple cortical cyst size 13 by 21 mm in the mid pole. And normal findings on urinary bladder.
See, there are many who say don't use the word mid-pole. Okay,
Interpole.
interpolar.
Interpole.
Yeah, right. So with regard to this mass, if you are the sonologist, or what additional things you would have given? I'm talking only at the report.
So description of the mass on the right kidney can be given as that there is distortion of the renal. Sir.
Yeah, continue. Yeah. And if you were the sonologist, what additional information you would like to give in such cases?
Distortion of the architecture with protrusion of the mass outside the kidney, so hence likely to be an exophytic mass lesion with mixed echogenicity within the mass.
And yeah, you are not able to tell. What I want is whether it is exophytic, whether it is endophytic, or it is both, whatever. Whether there is increased vascularity with the Doppler study, whether there is any distortion of the pelvic-calyceal system.
Yes.
Whether there are any obvious enlarged lymph nodes, whether the renal artery, vein, whatever, the Doppler, the flow is normal. Okay, because it's not a small lesion. I wouldn't expect the vessels and all those, the renal vessels to be commented when it is a small. When it is large, you know it can be associated with the IVC thrombus, renal vein thrombus, all that. So they should specifically mention it. Okay, I think they would have gone for cross-sectional imaging. The chest X-ray is normal.
Yes, sir.
Just a point. Why would you want LFT after the ultrasound? Who has made these slides?
Sir, Hardik sir, Puttavati sir.
Yeah. So when you make slides, don't put it just in any order, man. Anyway, go ahead. Priyanka.
Sir. We have these cross-sectional images of the non-contrast images of a CCTQB. So the left kidney appears to be normal in size, shape, and contour without any evidence of hydronephrosis or calculus. The right kidney appears to be distorted and enlarged, distorted in architecture and enlarged in size, with a lobulated lesion around the interpolar region and the lower polar region, which is exophytic, which is both endophytic and exophytic.
Those questions would arise if you can see most of the kidney. Can you see most of the kidney here?
No, sir.
Yeah, so it is almost replacing, except in one cut, it appears to be replacing the kidney. So
Replacing.
you describe it like that. What else would you like to describe in this film?
There is evidence of tiny calcifications within the mass lesion, You can see in the second image. On third image, it shows a vacillated appearance of the right kidney.
Where is the mouse and why is it roaming around where it is?
So,
Can you see the mouse?
yes. Sir.
So which structure was it on?
IVC.
Possible, yes. Why is it roaming around there? If it is
The mass lesion appears to be having a approaching the IVC, and there is some compression as well.
let us assume this is the IVC and this is the IVC.
Yes.
Would you be worried?
When you said compressing the IVC, when it is compressing, it should be compressed. It is dilating. I mean, it is expanding the other way.
Yes, sir.
Here in the third image, you may say that if this is IVC, it appears to be compressed. If this is IVC.
Okay, sir.
So now, if you answer my question, this is normal IVC.
Yeah.
So what worry do you have when you see an IVC like this, which is dilated?
So likelihood of a thrombus within the IVC, sir.
Okay. So the point I want to emphasize is that dilatation is a feature of possible IVC thrombus. You
Sir.
can't see the thrombus itself in many cases, but dilatation should raise a suspicion.
Sir.
Okay. So can we go to the next cut?
Sorry, sir. Yeah. So these are the contrast images.
Can we go back to the previous cut, Manish?
Yes, sir.
Just focus on the previous cut. This image, bring the cursor to the bottom left one. Bottom left. You don't want to comment on that? The cursor is moving somewhere around.
Yes.
Yes. You correctly mentioned about calcification. Isn't this mass very closely opposed to, in the second cut, all these muscles? And then what is all this? Something around the kidney?
Yes.
Around the kidney? What is all this around the kidney here? This black stuff. And then you see some small little white squiggly little structures around it. And then you go down to the bottom left, you see something more around the kidney, something thickened. And between the kidney and the thickening stuff, you see some white, small things.
Yes.
Yeah, they are all important structures. Important things to note when you have a mass lesion like this in the kidney, isn't it?
Okay.
You also mentioned that the left kidney looks absolutely normal in size and shape. But if you look very closely at that left kidney, you will see that the contour of that kidney in certain areas is, it's not smooth. It's not smooth. You have to look with a very discerning eye. It's not smooth. There's some little irregularity. What it is, we don't know. A lot of fat. And sometimes the presence of fat. Sometimes the presence of fat can cause a problem.
So, yeah. These are the arterial phase images and cross-sectional images of the KUB region. The left kidney appears to be having normal uptake, with normal contrast, enhancement of the parenchyma. On the right kidney, there is diffuse uptake of contrast with mixed enhancement around over the mass lesion. So we can see areas of hypovascularity within the mass lesion, suggestive of necrotic tissue.
See, you have to say which part is looking like a normal kidney, which part is a tumor, what is the enhancement of the kidney, what is the pelvic system details. Of course, you may get it in the later section.
What is this? Franco,
Sir.
what is this?
So that is likely to do cystic lesion, sir, in the left kidney, sir.
What is this?
This is the left renal vein.
So, why do you want to skip all that in your description? You seem to be stuck only in this. On this side, what all structures can you see, or what all structures should you be looking for? Just tell me that much.
On the right side, sir.
Yes.
Sir, the right renal vein, then the IVC, any evidence of lymph nodes in the hilar region or the paranephric region. The mass lesion itself and its enhancement, the pattern of its enhancement, evidence of calcification within, areas of necrosis, if there are within the lesion, and normal presence or absence of normally enhancing renal parenchyma.
Hey, just look very carefully. That cursor is going on moving. What is the state of that right kidney? Are you sure this mass is arising from the right kidney, or is it doing something to the right kidney? What is it doing? You just mentioned about the mass and described it fully, but you did not say anything about the kidney, because original cuts you did say something about the kidney. But what's happened in this contrast cuts?
Sir, the mass appears to be rising from the anterior aspect of the right kidney, sir, extending medially as well as laterally.
The right kidney at all? Can you see the right kidney at all?
Sir, in the posterior aspect, parenchyma can be made out, sir, on the first top left image.
You see, the kidney is sort of flipped and it's lying horizontal.
Yes.
It looks as though it is horizontal. It should not be there.
Okay.
There has been this mass lesion has altered the axis of the kidney. Very simple.
Okay, sir.
Would you be looking for the adrenal?
Yes, sir.
Why? Which adrenal would you be looking for?
Sir, right.
One bit of not caution, not advice, but just sort of clinical pearl, as it were. We tend to forget that the adrenal gland can also give rise to very large, bizarre, vascular, mitotic lesions. And because of the close proximity to the kidney, it gets very confusing whether this thing is arising from the kidney at all or not. But as bizarre as this, where the architecture, I think Dr. Manish or Prabhu mentioned in the first slides, that you can't make out where the kidney is and where everything is. And suddenly one cut shows the kidney flopped on its side and one lobulated mass all over the place. Always think adrenal.
Sir.
See the adrenal gland, it looks very bizarre, extremely vascular, necrotic stuff. Don't forget that this could be an adrenal carcinoma.
These are the nephrographic images where the renal parenchyma appears to be normally enhanced in the left kidney. In the right kidney as well, here in the first top left image, we can make out some enhancement of the renal parenchyma and its architecture. In the second image, we can see
Previous.
in the remaining images, you can see that the kidney is replaced by this bosselated structure with mixed heterogeneity and mixed uptake of contrast. So
You are not told the important part. If you remember the plain film, same cut in the left top.
The cursor was moving around somewhere
yes,
above some structure.
IVC, yeah. So
You should be able to tell, are you able to appreciate the renal vein, renal artery, the IVC? If you are unable to clearly demarcate it also, you will have to mention that.
yes, I can. This is the renal vein there, and
Which one?
This one?
yes,
Where it will go and open? No?
but it's that is likely to be the renal artery. It's going extending towards the aorta. Above that, the structure, rounded structure, is likely to be the IVC with normal appearing luminal content.
Does the renal artery arise below the superior mesenteric and celiac arteries, or is it all above? You look at the first cuts, you see the pancreas, and you see the artery going up and curling around there, and then you see the next cut. They have not yet shown you, except in the cut, that one. You can see from the left on the aorta, something looking like the renal artery coming in this point. Bring that cursor down to the aorta on the bottom left. Yes, just see the still there. That's probably the left renal artery because the kidney is sitting there and something is going there.
Yes.
So, you look at the sequence, which is the first artery, then you see where we are. You see, there is no renal artery cannot be in the first cut and the second cut on top. It has to be below those arteries.
Okay, sir.
You're already seeing something at the level which is above the renal artery. When you have a large mass like this, it will distort and angulate vessels. Look at this. Bring the cursor to the second film. Bring the cursor to the second film. Extreme right. Go. Yes. You see a white structure going towards it, and then coming around underneath that. Everything is being pushed down by this mass. So the renal artery, the renal vein, everything could be pushed down by this mass. So it will be all angulated. It won't come nicely horizontal like you normally do.
Yeah.
It's just that the possible sequence. That's all.
Probably this one, I don't know.
Yes, I think that is the right renal artery. It looks like contrast.
So now what is happening here? You look at this image, the first upper image, and you look at this image. What findings should you report as compared to renal parenchyma?
And so the enhancement pattern in both the kidneys, in the left kidney it is normal homogeneous enhancement pattern. But on the
I
right
understand
side,
that. All that I've understood. I want you to compare this image where the kidney seems to be, the tumor seems to be enhanced, and this image where it seems less enhanced.
yes,
This is obviously a later image. Kidney is
Yes.
still enhanced and this has become unenhanced or
Yes, sir.
less enhanced. So what is it called?
sir, wash
why
out,
does
sir. Early wash out of the
It's
contrast,
called
sir.
early de-enhancement. And why does it happen?
Sir, because of the increased vascularity, which is in renal cell carcinoma, there is early wash out of the.
Increased vascularity should call more enhancement. It causes early enhancement, which is less than renal parenchyma, and then it causes a de-enhancement. So what causes de-enhancement? If he is not answering, anybody is welcome to answer.
Sir, that is because of the wash out of the contrast from the vessels itself. So it is a vascular tumor.
Sir, AV aneurysm in the mass itself.
Yes, there are arteriovenous fistula in the tumor which cause early de-enhancement. Okay. So go ahead, Priyanka. What do you want? You have to tell us what you want.
These are the pylographic phased images here. So on the right side, we can see normal contrast excretion.
Okay. You seem to be stuck on the right side, but I'm asking you the question on which I almost failed my MCH exam. What are the CT findings of a simple cyst?
Sir, simple cyst will have a hairline wall without any evidence of septa calcifications. Within the lumen, there should be having water density without any evidence of solid components, and there should be absence of contrast enhancement.
You use proper terms. I understand you use the word hairline. So that is not used in simple cyst. So whatever the... Yeah. So don't agree, but don't use loose terms. Now that hairline is your own terminology. That's not used in simple cyst. If the simple cyst, we are talking of Bosniak classification.
Okay, sir. Thin wall, I should say, sir. It should be having thin wall.
Okay, go ahead. Go ahead. What will you do for the right side?
Are you happy with all the images provided?
No,
And
sir.
what is your concern?
Not sure about the evidence of renal thrombus, sir. IVC thrombus.
Okay, here they've given a reconstructed image, which is never a very good idea to look at, but let's say there's no thrombus.
Okay, sir.
They've actually shown what looks like to be the IVC all just pushed and compressed by the mass. It's also possible that you could see the right renal vein right on the top cut. The second. Yeah.
Priyanku,
Sir.
too pregnant a pause, man. What will you do? Quickly proceed. We have to go ahead with the class.
Yes, sir. We have to plan for radical nephrectomy in this case, sir.
Will you do biopsy?
Right-sided radical nephrectomy, sir.
Will you do biopsy?
Sir?
Will you do biopsy? What happened?
Yes or no? Will you do a biopsy? If no, why not? If yes, why yes?
Sir, no, sir. We'll go for.
Okay, agreed, but why?
Is it going to change your management?
No, sir. We have to proceed for radical nephrectomy in this case. It is evident of a malignant tumor, large tumor, 12 centimeter. So,
Supposing this guy has got multiple metastases in the chest.
So we saw the chest X-ray, it was normal.
Right.
No, so why are you so sure that it will be a malignancy? Do we have some numbers? Sambhaji says 70% likelihood of malignancy. Do you agree with that?
Is he a very conservative figure or is he a very, what shall we say, very low figure? See, these people are asked to just know whether you are confident of what you are saying and about knowledge base. That's all.
sir.
Previous question also was related to that fact only. Will you do a biopsy? Will you not know? There are certain situations where a large mass lesion like this, you would like to do a biopsy. But generally speaking, renal biopsies are for different situations for mass lesion. The next question that was asked is exactly on the same line about how sure are you that this is malignancy? One value was 70%. What is your value? Is it 40% that this is malignant? What?
So 95% of large solid renal masses are likely to be malignant. So, solid renal masses, please remember, and large. Small renal masses, the percentages change.
Okay, sir. Yes, sir.
Remember, there is no catch in any question. Put in a different way to know whether you are able to understand and what you are reading. That's all.
Sir.
So this patient had normal blood pressure. Suppose he had hypertension. How would the tumor be causing the hypertension?
Nice.
Dr. Nainan would have started counting on his fingers. 1, 2, 3, 4, 5, 6. Causes.
Yes, sir.
So difficult, huh? Not even one.
Can he have essential hypertension?
Sir. Yes, sir. New vascularization is one cause, sir.
But he doesn't have essential hypertension. Dr. Manish wants to know, can tumor cause hypertension? Straightforward question.
Yes. Sir,
What is the hormone, man? If you start speaking.
renin, sir.
Produced by the kidney.
Production of renin, sir. Renin hormone. Increased production of renin by the tumor is one cause, sir. Increased production of renin by the tumor, sir.
But still it is one only.
Malformations, arteriovascular malformations that are associated can cause. And other thing is mechanical. mechanical compression affects over the vasculature, sir. That can also lead to hepatitis.
Okay.
One more, sir. That polycythemia is one cause. Polycythemia resulting from increased erythropoietin production from the tumor can other fourth cause of hypertension.
Anything else? See, one is the renin-angiotensin, AV malformation inside the tumor. You said polycythemia.
Yes, sir.
Then there is intracranial metastasis. That's one of the last. There's 7. I don't remember all, but renal vein thrombosis, polycythemia. One of the other causes is intracranial metastasis.
Large causing compression of the renal artery and therefore increase, like creating a stenosis and then activating the RA system.
Okay, sir.
So, has this patient been operated? Are they?
Yes, sir. Patient underwent right radical nephrectomy, sir. HP report awaited, sir. Last week, just we did a radical nephrectomy.
So, what are the intraoperative findings? Are they?
Sir, this is large, sir, mass involving the posteriorly adherent to the posterior wall, densely, sir, and very close proximity to the IVC and IVC, sir, and renal vein and artery difficult to differentiate, sir. We have to flip the kidney totally, and then we have to go to the hilum because of that compression, sir.
Supposing you had difficulty to isolate the vessels, how will you proceed in this case? It's a large mass there. We said that you flip the kidney to go to the hilum. To flip the kidney, you have to tear it off from the posterior abdominal wall to which it was adherent. Any other way by which you can actually reach the renal artery, because this is a very vascular tumor, isn't it?
Yes, sir.
So you need to cut the circulation quickly, otherwise you will have trouble.
So, Priyanku, which would be the easiest way to reach the right renal artery? That's what sir is asking. You can see it here, man.
Yes, sir.
How will I reach this structure?
Interior group, sir, we go.
No, that's okay. But yes, correct. You look at it, look for it between the aorta and the IVC.
What is the danger in large tumors like this when you're operating? What catastrophic problems could happen as a result of doing a large nephrectomy like this?
Sir, injury to the large vessel, sir, IVC.
Okay, that's well. I'm saying catastrophic.
Sir, detachment of the thrombus into this circulation, venous circulation, and.
But Baba, there is no thrombus. There is no thrombus. Today the cursor is having a lot of work here. Huh?
What is this?
There are only 3 anterior branches of aorta.
One is far away from the kidney, one is close.
Superior.
Okay.
Superior mesenteric vessel in this.
Superior?
Superior mesenteric artery.
What about it?
Because of close proximity, it can be ligate, sir, by.
Yeah. Any other problem you can, catastrophic, in a large mass like this, any other catastrophic situation you can, apart from the superior mesenteric artery.
Yes.
What else? You can by mistake like the left renal
Contralateral renal means.
renal artery by mistake also, especially if you are going between the aorta and the IVC, in trying to get to the wall or to one side or the other side of the aorta, because the large mass, you may not be able to get the plane correctly between the IVC and the aorta, as very nicely shown on this picture.
Yes.
What is there in reality is very different to what is seen sometimes in the X-rays. And you may by mistake even ligate the left renal artery. Alright?
Yes. Sir.
Can you ligate the inferior mesenteric vein? What will happen if I ligate the inferior mesenteric vein?
Sir.
And nothing will happen, sir. If superior mesenteric vein ligated, then it will be causes. Sorry, sir. Inferior mesenteric vein can be ligated.
Can be ligated. Oh.
Yes.
It's part of the routine procedure sometimes when you are doing radical nephrectomy, transperitoneal, especially on the left side. You can ligate that in that mesenteric area and then open that window where you can go to the left side.
Yes.
So now you've done this operation.
Artery, man. Can I ligate the splenic artery? What will happen if I ligate the splenic artery? Huh? Sometimes in a large left renal tumor, you may mistake some vessel going across like that and you may ligate the splenic artery. What will happen?
All anatomy questions, man, you should be able to answer.
Splenic impact, sir.
If I like it, what are the collaterals which can support it?
Don't they do splenorenal anastomosis for renovascular disease?
Yes.
So if somebody can do splenorenal anastomosis for renovascular disease,
Yes. Sir.
you don't need to splenectomy, isn't it? Splenectomy is not part of the operation. Obviously, the spleen still survives. So how does it survive?
Gastroepiploic branches.
Anything else? It's not so much the gastroepiploic as the short gastrics.
Short gastric.
They are the ones that keep feeding the spleen on that side. All right.
Post-operatively, you excised this mass. There was a little bit of bleeding, but patient is shifted, and in the ICU, they tell you that refractory hypotension, not responding to anything. What all will you think of?
Bleeding.
Okay.
Post-operatively.
First thing. Okay.
In that case, to do blood transfusion as a first line.
No bleeding. Hemoglobin is staying stable.
Done a rapid CT, so perfect. Right.
So as a part of radical nephrectomy, we might have removed the ipsilateral adrenal. There may be absent of opposite adrenal. patient may go into Addison's crisis, right? Addisonian crisis.
No. What percentage opposite is
Absent.
Present.
So Priyanka, in 3% of patients, the adrenal may be absent on the opposite side.
Yes. Yes.
So you have to look for the opposite adrenal when you do your CT scan.
Cities. Yes.
Writing an additive. Sorry.
Yes, sir. Yeah.
The prognosis meant for this patient? What is the prognosis?
So, Priyanku, the histopathologist reports clear cell RCC and sends you back the report. And sir is asking, what is the prognosis?
Sir,
Can you name the prognostic criteria?
Mozart's criteria is, sir, risk of local recurrence is there, sir, which is after radical nephrectomy around 2%, sir.
No. Mozart's is for metastatic RCC. Is this metastatic? You are simply using some words so that. Is this for locally advanced local tumor or for metastatic?
Locally advanced, sir.
No, Mozart's is for metastatic.
No, so the question was that you're told that this is clear cell RCC. What are the other questions you would be interested in? Okay, so let me ask a different question. What is the current role of Furman's nuclear grade?
Lithotomy.
Yeah. Because we have to have a look at that area. Anastomos there.
You have any opinion on Furman's nuclear grade with current guidelines? For malignancies, I would suggest please keep up to date with EAU guidelines.
Yes, sir.
That summarizes most of the things well.
Did you say AUA or EA?
EAU, sir. I somehow feel the EAU guidelines are better written than AU.
Yeah. I think most people are using EAU guidelines for.
EAU, sir.
Okay.
There is a Furman and there is one more that is WHO ISUP. So they have told that the inter-observer variation, everything is much less with the WHO ISUP. So they have moved from Furman to this one.
Okay, sir.
1 second, I'll share the screen. Yeah, this is the localized RCC prognostic factors. Okay, this is the word which you have to use. Leibovitz. Okay, I think you can see now better. Leibovitz scoring.
Yes, sir.
2018. This is CC means clear cell, P means papillary, and this is chromophobe RCC. So there are, you can see what are the factors which points towards progression, which points to survival. There are 12. So this is what we were asking you.
Okay, sir.
So brand score model. These are all the prognostic model. One, at least if you say this one, Lebowitz, this is Lebowitz score is there. I will open one more. Yeah, can you? Follow. Yeah, this is the follow-up for patients who undergo radical or partial nephrectomy. Now, this is again based on EAU guidelines. Lebowitz scoring is there. You can see here 0 to 2, 3 to 5, 6 or more. And based again, this is based on tumor, nuclear grading, and all that. And this is the follow-up protocol. Low risk, intermediate risk, and high risk. And they are talking only about CT, how frequently it has to be done.
Okay, sir. 6 months, 10 months.
It's all there in EAU, just copied it.
Sir.
Again, it is different for clear cell and non-clear cell. The scoring is Lebowitz scoring, so you should be able to, because earlier we were using Mayo scoring, and then, this is for, again, you don't confuse it with metastatic. Metastatic, the follow-up is different. This is for localized tumor. Okay.
Very soon, I think they will put in the PET CT scan here because this screening doesn't look at PET CT. So PET CT is now being used for follow-up of patients who've had radical nephrectomy. Standard PET is more and more in favor rather than anything.
Okay. So this question was asked in I think 2 weeks or 3 weeks back.
What, Prabhu, which one?
Yeah, this prognostic criteria in follow-up of patients post-radical.
So very obviously, Priyanku, you are not answering these questions.
Yes.
Your loss.
Do you think on that day, on that those 2 days in the exam, you will remember everything and you can write? Despite,
Yes, sir.
you should practice it every opportunity. Then only you will be able to answer well.
Even if you did not know the names of all these scoring sheets, there are so many, each fellow has got it. You must have a general idea that what is the outcome of somebody who's got renal cancer. The bottom line is it's the most lethal cancer as far as urology is concerned. And then you look at the various factors. Any tumor, for that matter, the size is the most important criteria. Local T. So the size in RCC. So look at the size, the histological features, the presence or absence of lymph nodes, presence or absence of lymphovascular invasion, IVC thrombus. These are all the standard things which will cause it. So even if you did not know the name, if you could have just said that this is the fact, the prognosis of the patient is poor for these reasons, that's all.
Mm-hmm.
I don't think half the examiners remember the names of all these fellows. Each fellow has got his own grading system. Okay.
Yes.
Now this is different to the question that sometimes is asked as to what are the indications for lymphadenectomy in RCC. That's slightly different because that is based on the so-called Mayo Clinic criteria. Blut. Michael Blut and his criteria. So that's an intraoperative and done during surgery. So it takes into account both the pre-op as well as the post-operative. The intraoperative findings of frozen sections. Okay. Anything else? Okay.
Nothing from our side.
Thanks.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.